Hey everyone, good evening. My name is Fahad. I am a second-year student at NEOMED. We want to thank you for joining us in this evening, and we hope to have a very educational and a very entertaining event, which is our healthcare reform debate. This has been a topic at the center of American politics for years, for a good reason. Does this mean that we need a system where the government has to pay for everything? Do we need a system such as Canada's or Britain's NHS, where things like elective care become more difficult to obtain? As future physicians, knowledge of this topic is paramount. For this event, we're going to have 3 separate presentations given by individuals who have basically dedicated their lives to healthcare policy, and I'm going to briefly introduce them all. Joining us from Columbus is Mr. Todd Baker. He's the current CEO of Ohio State Medical Association, a professional organization that lobbies for Ohio physicians. Through his involvement with the OSMA, Mr. Baker has led physician education on healthcare policy with the expansion of roles from physicians, as well as the expansion of Medicaid through the Affordable Care Act.
So what I thought I could do today is, we're in Ohio. I will give you a little bit of a flavor of the Ohio experience, of how I think we've looked at healthcare reform in Ohio for the last 30 years that I have been here. And I ultimately believe, from our association's perspective, from the professional association's perspective, the ultimate solution is a public-private partnership. That there isn't one single solution on the private side or the public side that is going to solve what you've heard here today. So that's not necessarily an official position of the association written in stone, but if you cobble together all our various positions and what we've advocated for over the years, and I'm going to give you some examples at the end, some examples of hope at the end in what we're doing in this state, that I think addresses many of the challenges that you've heard from the first couple of speakers. So just some, what I want to try to accomplish today really quickly is talk a little bit about the picture you've heard today nationally, what that looks like in Ohio, what we see in Ohio as the major cost drivers, a little bit of a perspective on how the policy system works in Ohio that impacts coverage, cost, and access, the things that we've talked about. Part of what you've heard today is that clinical care is only part of the solution to better outcomes. And so what are we doing to address the social determinants of health in Ohio, in your community here, but across the state? And then what are those innovations? What are those specific innovations in Ohio? And when I talk about innovations, I'm not talking about the latest heart surgery. I'm not going to talk about the latest treatment protocol. I'm going to talk about how are we innovating our systems to drive for better outcomes. So you've seen the national data. This is the Ohio data. And you can see, obviously, the effect of Medicaid expansion in Ohio that Governor Kasich did about 12 years ago. We've moved 5% more of our population into the Medicaid system. But when you add it all up, you'll see that only really a little over half of our citizens are insured through private insurance. The other half of our citizens are insured through public insurance or are not insured. So in terms of raw numbers, how many people in Ohio do you think are on Medicaid? Any idea? We have about 11.5 million people in Ohio. So this percentage is a little bit misleading because we actually have a few more than this. We have about 3 million people in Ohio who are on Medicaid, because some of them are what we call dual eligible patients. They're both covered by Medicare and Medicaid, and they're primarily showing up here in Medicare. But about 3 million people. So when you go out and practice, if you eventually go out and practice in Ohio, about one in every 4, 1 in every 5 patients that you're going to see is going to be a Medicaid patient here in Ohio today. That number will probably grow after you're done with your training. So when we think about what drives cost in healthcare, particularly in Ohio, it's the same as what you've heard already, but I want to talk specifically about the technology component. Obviously, we are utilizing more healthcare per person. That drives cost. You've heard about the administrative cost. You've heard about the cost of medication. New technology is a significant driver in healthcare. If you talk to and I'm not a physician, but if you talk to the two physicians in front of me, the biggest change in the way people practice and education is that the breadth of what you have learned, or the breadth of what you will practice when you get out, is becoming less, because the depth of what you need to do is so much greater. Because we are becoming more and more sophisticated. And why is that? Well, most of that is being driven by technology. Okay. And so our challenge on the cost side, and this gets at how we cover it all, our biggest challenge is, how do we not stifle innovation, but cover from a physician? When you are dealing with a patient, you don't want to have to worry about cost, right? You want to take the best possible care of that patient. But the return on the investment 50 years ago to that next innovation was a lot greater than it is now. So for example, that next thing you did 50 years ago, that next new innovation that you did, provided a multiple better outcome, right? Now that next data innovation gives you this much of a better outcome. And who's going to decide that you do or not, that you can or cannot get that and give that to the patient? That gives you that incrementally, just little incrementally better outcome. And I think part of the challenge that we have is, if we go to a single payer system, or if we go to a government-run, completely government-run healthcare system, that who is left up making that decision? And you can argue, well, would it be better the government do it than some insurance company do it? So when you think about how this is going to impact you when you get out, okay, and start practicing, think about it in the context of what it will mean to you and the physician-patient relationship that you have, that you hear about in your training, that is sacred to what you do. All of this will impact that. So how as you as physicians can impact this process? And that's why we're here tonight, right? How can you do that moving forward? You've heard a lot about the federal government. Let me tell you how you can impact this process at the state level, regardless of what type of coverage we have. We have a system in Ohio where we have a House and a Senate and a governor, and they all have impact on healthcare in Ohio. The legislature makes the laws. The administration, in most cases, puts the laws into place. So you can be an advocate today. You can be a healthcare advocate today as a student, and you don't have to be political. You don't have to know anything about the political system. So within the last year, we have written rules in Ohio about how you can use telemedicine, right? That will impact delivery, that will impact cost, that will impact coverage, okay? Those rules were written by the legislature and now being implemented by the medical board. And you as a student can comment on those rules as they're being written and help decide the impact of them. That's how you can be an advocate. It's as simple as that. You can become involved, and you can look at rules that are written in the state that impact your healthcare license, okay, your medical license when you get out, your ability to practice medicine. So being an advocate in how you can be part of this process, whether it's a single payer process or some other process that we're talking about, you can impact that from today throughout your medical career by being an advocate. And if you walk away with anything tonight, it's that you can affect the change. You absolutely can affect it from this day forward. And our organization can certainly help you do that while you're in training. So that's your role. Whatever this system ends up being for the 40 years that you're out practicing and being unbelievably great physicians, hopefully most of you in Ohio, you have the ability to impact that process. So most of what we've talked about is clinical care. What we know, and we've heard in a few slides tonight, is that is only a small part in determining outcomes. And yet, the way that we provide care, the way we holistically provide care in Ohio and in most other states, is there's a pretty significant divide between clinical care and community-based care, right? They leave your exam room as a primary care doc. You may not see them again for 3 months, 6 months, a year. What are they doing between the time they leave your office till the time you see them again? And yet now you're being held responsible for their outcome. And yet much of what you can do for them, okay, is, or much of what will impact their outcome, you do not have effect on. So one of the things we're trying to do in Ohio, and is being done in other states, but it's being done collaboratively through public-private partnership in Ohio, is to connect the community healthcare world, these social determinants of health that affect your outcomes, with the clinical side of care. And that's being done innovatively, and we'll talk a little bit, I'm going to talk a little bit about that. And I think that is a system that ultimately will lead us to the better outcomes that we have talked about. The real issue is, how do we cover and pay for those? How do we cover and pay for those things that are outside of the clinical space that we know have big impacts on healthcare? So two things that we have in Ohio I would encourage you to learn more about, and I'm going to give you a snippet of what they are, because it is the key to linking the community side to the clinical side. We have what is called the Ohio Health Information Partnership that has been around in Ohio for about 15 years. And what that started from was really to get EHRs in everybody's offices, really as a way to get EHRs out in everybody's offices. Now what we're trying, and so now we have free-flowing data between hospitals, doctors' offices, insurers, and to some degree, the government, where we are sharing health information about patients to lead to better quality and better outcomes. That has not been done by the government by itself. That has not been done by the private sector by itself. Ohio's Health Information Exchange stands out nationally because it was built from the beginning as a public-private partnership and now is self-sustaining on its own. And the change that Health Information Exchange is making now, and I note it's going to be called Unite Ohio, is that it is creating an infrastructure to now not only share clinical information, but connect you as a clinical clinician with the community-based resources. So how great would it be for you to know if that patient has diabetes and you have said that there are food resources in the community that they can access? How great would it be every day if you got a data flow into your system knowing if that individual accessed the healthy food option in their community? How would that empower you? How would that better empower you to treat that patient moving forward? It all can be done in the future through this data connection that will connect community-based resources with clinical-based resources that you as clinicians will be able to access and see. And that leads me to my last point, is that ultimately where I think some significant solutions to this problem, this overall problem, can come from, we talked about it as a group a little bit earlier, is you as physicians, you as a physician group directly contracting to provide care with an employer, to take care of their employees, to cut the government and the private insurers out of the system, and have you contract directly with people, whether it's individuals or whether it's employers. And you can say to them, how much do you pay for healthcare today? Well, we pay $5 million for our employees. Okay, I'll take care of your employees for $3 million. And I'm going to make them healthier. And you will be in charge of their healthcare. And you'll assume the risk if you don't provide good healthcare for them and it's more expensive. So I think from the professional association's view, I think there are opportunities. I think the ultimate solutions are public-private partnerships moving forward that are innovative, and that rely on both the clinical and the community-based care. And the last slide I will put up here is a plug for all of you. And I mean the two physicians in the front and all of you as physicians in the back and everybody in between. You can't take care of your patients, and none of this matters if you're not healthy. We lose a medical school class a year to suicide in terms of the number of physicians that die from suicide in the United States. It equates to a medical school class every year. None of this matters if you're not taking care of yourself. And as a profession, we have a responsibility, and you now have a responsibility to take care of each other. So what we have done in Ohio to help students, residents, fellows, people in practice, retirees, and not just physicians, but any healthcare worker. We have created a well-being service that does a 10-minute assessment and links you with mental health services that are defined by how you've been assessed. Completely anonymous, completely free. So at any point that you see a colleague that might be struggling with mental health, and it's a really difficult conversation to have, right? It's a really difficult conversation to have. There's now a resource in Ohio that you can point them to. And you can say, hey, you can get a quick checkup and you can get referred to services that will help you from a mental health standpoint. So while we're here tonight to talk about the system, what I don't want it to be forgotten is the system is made up of people. People like you taking care of people. And we first need to take care of all the people that are taking care of people. Thank you.
Dr. Reyn Archer, he's an OBGYN physician who was the Texas Health Commissioner, a congressional chief of staff, and a policy consultant. He's helped to fashion laws that were signed in by President Bush in 2003, and has successfully led the state implementation of the state children's health insurance program in Texas, as well as developing the neighborhood health initiative in North Omaha with African-American community leadership. Dr. Reyn Archer will be representing the Benjamin Rush Institute, which does not support the single-payer health reform as a theoretically best way to care for the U.S. population.
You can tell Dr. Ross has a big heart, and it's important that we understand the idea that medicine is a profession to heal, and it's a profession to care for people. And it also is important that what we try to do is to understand what our goals are, but to also be pragmatic about what's even practical. And so I'm going to talk a bit about the journey that I've taken as a physician and in the public health service and running a health department and working in 20 countries around the world. And the last 6 years I've been in Congress writing healthcare legislation, and how difficult it is to actually achieve the goals that you might set out to do. And I'm going to talk through some of this and talk more about, I believe the question is really not about finance, but it's about health outcomes. And we have to, as a nation, decide to take the parts and pieces that we put together, take them apart, and rethink the equation to assure that the goals that Dr. Ross has set have been put in place. But I do not believe government alone can do that. And I also agree that the problem that we've had with the free market system and the reforms have been stymied to a great extent. But I think there is a different path. And so I hope you'll look at this and consider it. So I've talked a little bit about the things I've done. If you look at the Winnebago Omaha Tribal Hospital, I went to Congress because my congressman from Nebraska was concerned that the Winnebago Tribal Hospital had been closed by CMS because the Indian Health Service, which is a government program, which is government financed and government run, was killing patients in the hospital for many years. And CMS went into the hospital and had to close the hospital down because the Indian Health Service, part of the federal government, couldn't run the hospital. And the hospital stayed closed for 3 years until I worked with the tribe to help them take over the operation of the facility and provided the resources for them to actually hire people who were loyal to them and loyal to the community that they were in, but the federal government itself couldn't do it. The second thing I think is important, I worked on insulin costs. We had a young man named Matt who was 13 years old from Tacoma, Nebraska. At the age of 13, he was diagnosed with type 1 diabetes. And he went to the pharmacy, and the first time his insulin was $60. The second time he went later in the month, it was $600. And Matt wrote my congressman and said, I don't think this is fair. And I said, I agree with you. So I spent 3 years writing Matt's Act, which you can find online. And we were going to make insulin $20 out of pocket for every single patient. But we were also going to do one other thing. And that is the way the government has set up the system for drugs and drug pricing, the government set the system up. A vial of insulin is $350, and 80% of it goes to the middlemen, the pharmacy benefit manager, the insurance company, and to the pharmacy chains. And when we tried to write a piece of legislation to take them out of the loop, we could not get a single other member to help us, because every single medical association, the American Diabetes Association, the Endocrinologist Association, the Diabetes Educators Association, they will not help you because they all get money in the system directly going around. So yes, we now have $35 insulin in Medicare, which is in this new bill that was passed, but guess how they did that? The taxpayer is paying, again, the government set this up. The taxpayer is paying the middleman the $300 so that the patient doesn't have to see the cost. But we're still paying it because we were unwilling to fix that problem. So what I'm trying to say is it's really easy to say we're going to fix a problem, but it's better to hide the nature of the problem than to actually get to the root cause of the problem, no matter which party you're talking about. So I want you to really understand changing healthcare is extremely difficult, and getting it right is even worse. I'll talk about one more thing that I did. We talked about the Obamacare or ACA. It was an important step, but when we realized that if you're below 400% of poverty, it protects you. It does a really good thing for you. But if you're above 400% of poverty, you're paying sometimes $3,000 a month for your insurance. So it was helping many, but it was harming many. So at the max, we had 11 million people insured by the ACA. By the time we were working on this, it went down to 8 million. Most of the expansion in the ACA was into Medicaid. So we worked with 5 Democrats and 5 Republicans, and we got an agreement to solve the problem by changing some of the context of the ACA. And we got this close to passing that piece of legislation, but John McCain didn't know the changes we'd made, and he voted against us. So we lost solving the problem and repairing the real problems of the ACA in Congress. It's really hard to change things. The other thing I did earlier is I worked with Bob Bennett and Ron Wyden. Ron Wyden is a Democrat from Wyoming, and Bob Bennett is a Republican from Utah on the Healthy Americans Act. This was a solution that competed with the ACA, in which you could, we were going to give everybody a defined contribution to go out and purchase their health care, and we would make it according to their income, a sliding scale. Then they would go into the federal program that's the federal employees health insurance, which forces every single insurance company to compete at at the top level of competition. But the insurance companies worked with Max Baucus, who was the Democrat leader of the finance committee, and convinced him that it was better to pay them more through the ACA rather than to do the Healthy Americans Act. So again, you have to understand changing things. It's very odd. You think you have people who support ideas on one side, but you got to look at the ideas, not who the supporter is. Last thing is we, I'm very proud of this. Over the last 3 years, my boss's congressman, his brother-in-law had ALS, and he had been in a clinical trial, and that clinical trial put him into the placebo arm, and he was dying, and friends of his who were in the non-placebo arm were getting better. So my congressman said, go see if you can get him the drug. Now that the trial is over. I went to the company and they said, I can't help one. I said, okay, let's help all of them. Every single patient in the trial. And so we created a solution called the Act for ALS. We ended up working with a guy named Brian Wallach, who is in the Obama administration, and he has ALS. And when we passed that bill a year ago, Anna Eshoo, the Democrat chair of the Energy and Commerce Committee, said it was the most popular bill in Congress. And we forced FDA and NIH and to think differently about patients and differently about trial design and differently about innovation. And it was a major accomplishment, but it took a lot of work from people all across this country. And I'm very proud of that work. I wrote the bill. I believed in it. I got it passed. And so it's possible to make change. So here are my principles. Insurance matters, but only mostly because it deals with creating equity and assuaging anxiety. But insurance alone doesn't mean anything, really. It doesn't actually lead to health. So insurance doesn't even guarantee access, which Dr. Ross talked about. And then finally, not all access is the same. The presence that you as doctors bring to the possibility of your patient is more important than the prescription you write. If you don't pay attention to the person in front of you and know their name, it doesn't matter whether you care about whether they have enough money or not. You have to be present to that person. And if you cannot be present, what kind of system have we created in which so many of our physicians are being owned and then are being forced to see more patients than they can see? This is not right. But I'm going to tell you, the government is complicit in this problem. To think the government is benign is a mistaken assumption. So insurance is good, but it doesn't predict that you're going to have better health outcomes. And our behaviors are very hard to change. And doctors are really not very good at changing people's behaviors. Not only that, nutrition is one of the most important things, and you get almost no education in nutrition. And if you look at the American Heart Association, the American Diabetes Association, they're all making recommendations for nutrition that is actually making people sick. Those are your organizations that are doing that. So the number one determination of health outcomes is how do you get along in the very family you're in or in the community you're in? And Christopher Murray is the top epidemiologist in the world, is at the University of Washington. He's showed us that 3 of our most healthy populations are our poorest populations. So it's not about income, it's about how people get along. Our system, even with universal health insurance and access, is not set up to improve health. It really is not. And the government can ensure coverage, but it cannot force and is not giving us the tools to bring better health forward. So I believe an ideal system should ensure coverage for entire population and particularly at the lowest cost. We went and negotiated the ACA with Blue Cross Blue Shield and included high cost medicines, maternity and women's health, hospitalization, rehabilitation, and mental health. Those 5 services in a catastrophic care plan. And we took that $3,000 policy in the ACA and took it down to $400. But the government won't let us do that. It will not make that available to people. So if we then did that, had a catastrophic plan, and then had everybody held a health savings account, which I created with my father, who was chairman of the Ways and Means Committee, if the dollar's in your patient's hands, they have a lot more control over the process than if they don't have the dollar in their hand. So if we had a catastrophic plan and an HSA, we could insure everybody for $2,000 a year and have excess cash, but the government will not let us do that. So we can address unique needs but we also have to address different needs for how they access care. You know, a lot of people who live in poor communities, they show up in the emergency room at 9 o'clock at night. Maybe we just need a better walk-in care system like I've seen in Cuba and Russia and other parts of the world where we don't have insurance. We just pay for their care when they are low income. So we don't put the burden of primary care on them. And we use the systems that have been worked on in other countries. Our community health centers could do that, but they're also intertwined with promises of 100% payment for every single visit. So they are not ideal in that regard. The other thing we talked about, tethering the dollars to patient and doctor. We need to honestly look at cost, access, and outcomes. We need to sustain innovation in this country. There are lots of jobs in economy and innovation, and we are the leader in the world in innovation. And if we have a single payer system, we try to draw all the money out, we're also going to lose some of the innovation. And that's the scientific training that goes on in medical schools, and the research, and all the different things are all predicated upon this swirl of money that's way too much. And we have to have the ability to constantly reform. As Denny Cortez, who ran Mayo Clinic and worked with me on the issue of Ebola in the Dallas Presbyterian Hospital, I was on site working with the hospital to try to understand the moment. He said, we need a fund for the science of healthcare delivery. We need a fund for the research on healthcare delivery. And I believe that we can put these parts and pieces together to really drive what is free market, what is health outcomes, and what is just and humane, and for you as physicians, just and humane, but not through a single payer system. So when you think about Washington, we talk about finance, we talk about delivery, we talk about outcomes, we talk about research and disease. But really, when you think about the levels of intensity of investment in time and energy, it's almost 80% in finance. In Washington, D.C., you can hardly talk about anything. If you talk about NIH and specific diseases, you can't direct anything. You give more money to NIH and they decide. So in ALS, we want to give more money to ALS. They will not let us do that. Congress cannot direct those dollars. And so you have integrated delivery systems as well, and that's part of the discussion, but we just fund them and they go and run or don't run. So really the dialogue in Washington and the money in Washington is all around either single payer or this patchwork quilt that we've talked about. So we've gone through this a little bit. You know, 68% are on any private plan. There are ERISA plans. They've been set out in the post depression era to try to retain employees through what are called ERISA plans. And so 68% of Americans have what they would call good private insurance. Many of the rest of these folks have minimal coverage. And many of the people in Medicaid have a very difficult time finding access to providers because Medicaid pays less well and Medicare pays less well. If our rural hospital had to rely solely on Medicare, they would all go out of business because they don't generate enough money through Medicare reimbursement. We also have seen, as you can see, the chart starting in 2009 with the ACA, you saw drops in those who lacked insurance company coverage. This is a good thing. And so it's important that we get to this last 10, 15% that are not covered. And we've already talked about this issue of out-of-pocket or total spending. But what's interesting is America, in terms of out-of-pocket spending, is really not that much out of alignment with all these other countries. So yes, we spend more on total cost, but on average, for example, the Swiss spend almost 3 times out of pocket compared to the United States. So here are the rates of folks who are insured by state. So the very light blue are states that have less than 5% who are uninsured, and the dark blue states, like my original state of Texas, has 12% or more who are uninsured. Florida the same. And it's interesting, obviously, that Ohio's kind of in the middle. But what's also interesting is that just because you have higher rates of uninsurance doesn't mean that your health outcomes are worse. So Florida and Texas, surprisingly, have better than they ought to health outcomes. And some states like West Virginia and Kentucky and Tennessee, which are heavily insured. Tennessee was one of the first states to actually insure everybody through TennCare, but their health outcomes and their longevity is worse than other states that have much higher rates of uninsurance. So if you compare them, you can see there's some overlap, but it's not causative in the sense of uninsurance and health outcomes. And maybe this is why. So Dr. Ross talked about the fact of our spending compared to others, and also our life expectancy. You can see around 2014 that our life expectancy started to drop. And then with COVID, it dropped quite remarkably, quite dramatically. Dr. Deacon at Princeton noted 2 years ago that we had loss of almost 600,000 people between 45 and 54 from suicide, alcohol, and drugs. We've never seen this in this country. This is not about health insurance. This is about desperation and something wrong. There's something rotten in the state of our country that's driving these issues. And this is not going to be fixed by national health insurance. On the other hand, conversely, you know, we have far less of cervical cancer in the United States than in Britain. Their rate of cervical cancer is 3 times the rate of the United States. And our breast cancer screening is much better, and our treatments for breast cancer are much better. Our flu vaccines are much better. So it's not like we're worse than everything. We have certain things that we do reasonably well. But I believe our primary failure is in our poor diets and our national social structures. So when we look at obesity in America in 1991, you can see that the highest rate of obesity in the red was 20%. And that had progressed from 91 to 2000 in a decade. But stunningly, today, the lowest rate is 20%. And we have some states that are approaching 50% rates of obesity. How did we do this in just 30 years? The government is complicit in this. Do you know Coca-Cola, 41% of their revenues are in the SNAP program, the food stamp program, and you cannot touch it. Think about that. Our government is giving people the food that makes them obese, to make them sick, to end up driving up the cost. And then the tribal hospital, for example, in Winnebago was telling me they did an assessment of diabetes, and they found that 26% of their adult population has diabetes. And they were proud that they could build a dialysis center to make some extra money. So we're building dialysis rather than understanding the roots of our illness. That's what America has become. That's not going to be fixed by national health insurance. So we have the highest chronic disease rate in the world among similar countries. So I'm going to take a small sidebar step. So Al Tarlov wrote these books. He became one of my mentors. He had been the head of medicine at the University of Chicago for 20 years. And he went into the community of South Chicago and he provided 10 years of primary care and then another 10 years of primary care. And then the second 10 years, he added health education and health promotion, prevention. And he said at the end of those 20 years of all that effort, he said, I had a zero effect on every single health measure. Because what he says is that, as I said before, 20% of your health outcome is your health behavior, 10% is your genetics, 15% is medical care, but 55% is how you get along in your family, how you get along with your neighbor. You can't fix that with national health insurance. And in my own state of Texas, which Harold Varmus was then the head of NIH, and he came and presented at the 50-year colloquium for Michael OBrien, who was the first to do open heart surgery in the United States. And Harold Varmus talked about the Human Genome Project and targeted therapies. And then he showed a map of the United States with counties all over the United States with age-adjusted mortality rates. And Texas was quite interesting because it was the only state with this tremendous heterogeneity. But if you look at the border with Mexico, this is the border with Mexico at the bottom, 90% Hispanic. If you take them, they would be the poorest, least access to healthcare, least access to insurance. They'd be the third healthiest state in the United States. And what's interesting is when African Americans and Anglos live with Hispanics, they live longer. So I'm almost done. The United States is fourth in the world in index and innovation. We're 14th on the index of quality. We're first in the rank of choice, and we're the last on affordability. But there's an important thing in terms of innovation and drug trials. This gives you a sense of how many drug trials we do as compared to the rest of the world, 148,000 versus Belgium with 11,000. And this is the second to last slide. So here we are in 2023, we're going to have inflation. And this is what Medicare is going to do in the process of trying to fix inflation in the healthcare system. They're going to give a raise to hospitals. They're going to give long-term care facilities and nursing facilities and outpatient hospitals and surgical centers all are going to get raises. But there's one group that's not getting a raise. And what is that group? Physicians. They're going to get a cut of 4.5%. So America's innovative. We have poor protoplasm. We have a patchwork quilt. The fully insured states are losing life expectancy. ACA is designed for good, but it's terrible for those above 400% of poverty. We have a $35 insulin, but $300 to middlemen. ACA does not allow benefit redesign, such as for direct primary care or catastrophic plans, and CMS should allow states to be true innovators, but they'll only give money to states that'll sprinkle money around as social determinants of health, like air conditioners. As one guy who is a liberal guy in North Carolina says, it's all about being Santa Claus for the government. And that just doesn't work. So here's my solution. We need to have a defined contribution like the Healthy Americans Act. I'd like to give HSAs to everybody in Medicaid. We need benefit redesign. We need to force insurances to compete. And we need to allow people to buy into the federal plan. We need to have walk-in clinics for poor neighborhoods, and we need to have direct primary care for every single other patient. We need to fund the science of healthcare delivery. We need new delivery systems for patients with complex diagnosis in Medicare. And we need new incentives to drive the patients and system. We need to use behavioral economics to really change the system. And then finally, this is my own unique drive, and I didn't talk much about it, but we need a moonshot for prevention. Prevention is about community. We need health data. We need health data utilities. We need to invite the community into absolute full participation in what goes on with them. And we need to share the data, and we need to understand how when we create savings by improving health, those savings should go back to the community, not to healthcare companies. So I believe we can do that through free market systems and really care about patients and care about you. But the battle is still going to be a battle, whether it's for a single payer system in which you give all power to the government and hope one day they'll do it right, or we fight incrementally and pragmatically through these incremental processes that are in front of us. So thank you very much.
Joining us from Toledo, Dr. Johnathan Ross. He's an associate clinical professor of internal medicine at the University of Toledo. He's the past president of Physicians for National Health Program, a national health reform group with over 17,000 members.
I've done just about everything that a doctor could do in addition to doctoring. I taught and practiced actually primary care internal medicine at St. Vincent Mercy Medical Center for 40 years in a Center City clinic, but I also spent 2 years in the National Health Service Corps, taking care of a rural poverty population as a primary care doctor there. And was an HMO medical director at one point. So I saw, for me, what I would call the dirty underbelly of the insurance industry. And after deciding that there was no good work to be done there, decided that I would actually get involved in looking at health policy and health reform. So I'm going to go ahead. If this is my slide set, we'll see it. So why should we worry about health reform? You know, first of all, you should be a lot more worried than I. You know, my career is at an end, but yours is going to be coming up, and you should really be seriously thinking about what kind of environment you want to work in. Well, compared to other rich nations, our costs are out of control, our outcomes of care are mediocre at best, our access to care is deteriorating, even for people who have insurance. We've got about 30 million people who continue to be uninsured despite the Affordable Care Act, and 90 million who are underinsured and remain at risk of medical bankruptcy or economically crushing medical debt. Those are the facts, and I'll show you the data in a minute. This isn't a new problem. We've been talking health reform since Teddy Roosevelt first introduced the idea when he was running on the Bull Moose Party. Now, it's probably a whole nother hour to do this history. I highly encourage you to go back and read what we've been through. But every one of these presidents, Franklin Roosevelt proposed it, talked out of it by his good friend, Dr. Morris Fishbein, who was head of the AMA, said he would crash the entire New Deal. Harry Truman actually had a bill in front of him. It's called the Wagner-Murray-Dingle bill. He tried to pass it twice. Again, very strong AMA opposition at that time. Lyndon Johnson managed to, because Lyndon was special. Maybe Rayne, I don't know, did you ever meet Lyndon Johnson? I bet he did. Anyway, Lyndon Johnson was special. He was in the House, he was in the Senate, and he knew the dirt on everybody. And he was a pretty engaging guy, although a bit profane. And he actually got Wilbur Mills to work with him to create Medicare and Medicaid, which was an important lesson, and it's a lesson in the future, which is you better have the committee chairs involved in your health reform or it isn't going to happen. Richard Nixon actually knew that the Kennedy brothers were going to run on some sort of national health insurance, and he needed a plan. He had a friend, a guy named Paul Elwood, who was a physician running an HMO in Minnesota, and he went to him and he said, hey, HMOs, I'm telling you, Richard, President Nixon, they save money. Oh, that's all he needed to hear. And they created something called the HMO Act in 1974. And it said that any business with more than 500 employees had to offer an HMO if one was available in the community. And what that set off was it accelerated the progressive corporate takeover of healthcare, which is proceeding apace right up till now. And again, too much to talk about here, but I'm going to just, again, touch on Clinton didn't understand he needed committee chairs. He sent his wife and a bunch of policy wonks into a dark room to decide what kind of healthcare we all ought to have. Came out, none of the committee chairs had any stake in it, never came to a vote. It was kind of, okay, let's create a bunch of big HMOs, and then you have to pick one or the other to get everybody covered. But he did have success, again, by working through committee chairs and more normal processes with the CHIP Act. And I guess, Rayne, you know about CHIP, working on it in Texas. But that was a children's health insurance program, which is a very important piece of trying to get a gap in children covered in the US. And that happened late in his second term. Obama had been a legislator, both in Illinois and in the Senate, and he understood the importance of committee chairs. All he did was say, I'll spend $100 billion, bring me a bill. Now that bill barely got out of Congress. There's a whole nother huge story on that. In any case, we ended up with the Affordable Care Act, which did expand Medicaid, maybe got an additional 20 million people in there and a few other millions of people that are in the marketplaces. But there was a huge effort put in to try and repeal, which I think, again, Rayne knows a lot about. I want to pick his brain later because I don't know the inside deals on all that. But again, it failed after multiple votes to repeal it. So we're still talking about what's next 110 years later. So this is, I'll give you some data now. So this is the healthcare costs per person in each of these countries. And as you can see, the red line is us, and we are almost double all these other rich countries: Germany, Switzerland, Austria, Sweden, Netherlands, on and on. So we're twice as expensive. And what you need to understand is that those extra dollars that we're spending on healthcare, basically they are baked into every single product that we try to produce and sell overseas. So this is like a tax on exports. Functionally, our high healthcare costs are basically a tax on our own tax on ourselves, on our own exports. So we really need to look at that number and try to figure out how it is that all these other rich countries, which are capitalist countries just like us, have managed to do it for a lot less. It's even worse than it looks on that slide, because this is a little dated, because here we're talking 11,600. This is, I think, 2019 data. But the important thing I want to talk about is the bottom, where we're actually showing how much money we spend when you include the subsidies. So we've got tax deductions for business and for individuals. We've got all the public employees that we take care of at every level, at the village, states, county, the cities, nationally, and the employees of the VA. Everybody's getting private insurance. So those private dollars are coming through the public pocket originally, because those are all publicly sponsored organizations, right? So when you pay your working people in government, you're paying them benefits. Those are tax dollars. So when you actually look at tax dollars, we're even higher in terms of the amount of money. So here's my point, is that we're paying for a national health insurance program and we're not getting it, right? Money is not the issue. We're putting enough money in. We should be able to have a complete program with everybody in, universal, for everybody in the country. Life expectancy, this has actually dropped recently, probably because of COVID, and to some extent our struggle and world struggle now with COVID. But what you can see is that those looks, hey, that's what, 2-3 years, right? That's no big deal. No, a lot of young people had to die early to drop that life expectancy. And so what that really reflects is probably a lot of people who should have gotten better who didn't, for one reason or another. And there are lots of those reasons. Infant mortality and maternal mortality are things that almost every public health person looks at as a measure of effectiveness of our healthcare system. You can see ours is worst among these rich countries, twice as bad as, say, Sweden's. We've got maternal mortality, which is 4 or 5 times worse than many of these countries. In one case there, it's more than 10 times worse compared to Australia. And this is a busy slide, I'm sorry, but if you look for the red line, that's the Organization on Economic Cooperation and Development. This is kind of apples to apples comparison. And this is where we can really see for sure that our healthcare system is suffering, because our preventable mortality and our mortality from treatable diseases is way down there at the bottom of this row. I mean, I don't have a pointer, but on the preventable mortality, it's probably about 8th or 9th up. On preventable or treatable mortality, we're just maybe 3 or 4 below. So we're between the Czech Republic and Costa Rica on treatable causes of mortality, and we're between Chile and Slovenia in terms of our preventive mortality. I mean, that's not where we should be spending twice as much as these other countries. So the fact is that our system, if you could call it a system, lately I've been calling it a sickness care non-system, it's not functioning in a way that it ought to, given the money we're putting into it. So we're paying for it, we're not getting our money's worth. Now, right now, because of higher and higher co-payments and deductibles, people are self-rationing. This is data from Kaiser Family Foundation. They did interviews and they found that approximately 31% of Americans were not going to the doctor when they thought they should and tried home remedies instead. Got another 30% skipping dental care. We've got 26% skipping medical care, another 21% skipping recommended tests or treatments, and 12% having trouble getting mental health care. And if you looked at that and added it all up, it's about 51% of the people that they interviewed in this study that said they were having problems affording care. And 13% of the population said because they couldn't afford care, their condition got worse. So right now, it's kind of like there's something called the first rule of holes. Are you familiar with the first rule of holes? When you're in a hole, stop digging, okay? So whatever we've been doing, it's making us worse, not better. So it needs to be carefully scrutinized. So here's kind of a bunch of guys, mostly smiling. It's interesting, the guy who's making the most money kind of is scowling. That's United Health Group. For me, they're the Antichrist of health insurers, just if you want. I mean, they are, for me as a primary care doctor, working with them was really pretty tough. We had a very difficult time with them for the most part. But anyway, these guys are all making what, 8 to 25, 27 million, 20, anyway, making a lot of money as a health insurance executives. Okay. Do you know who that is? That's Chiquita Brooks-LaSure. She is the CEO of Medicare, Medicaid, and the federal marketplaces. Now, the biggest insurer there is taking care of about 50, 60 million people. That's United Health. She's responsible for about 110, 120 million people through those programs. And we pay her $210,000 a year. Now, I'm not trying to belittle that. What I'm saying is that we can get good people to run our healthcare system for a lot less than $27 million a year. Okay? I don't think we need to pay people that much. I'm sure we could get good neurosurgeons for less than $1 million a year, and some of them are making that. So the point here is that we're spending a lot of money, and you have to start asking, why is all that money going there rather than into care when we have 10 million uninsured? Well, again, they're business people, and they're just doing what business people do, which is trying to make profits for their shareholders. And right now, basically, it's almost built into the law with the ACA that the amount of money that they spend on medical care, which they call a medical loss. So your care is their loss. They want to keep as much money as possible. And that's running an individual market from around 30% to the Medicaid managed care, where it's as high as 89%, which means that 11% is going to administration and profit in the Medicaid area, and maybe 30% going there in the individual market. So we're spending a lot of money. And the question again is, why are we spending so much money on administration and profit? And what I'll tell you is that it's the complexity. If you want the actual simplistic answer, it's the complexity. So I don't know, is that top showing up for you? It's a little buried there. But basically, they looked at what percentage of all of our American healthcare spending was taken up by insurance administration and profit. It's about 12%. We're spending about $4 trillion. Somebody can do a quick thing on their calculator and figure out how much money that is, but it is a pile of money. You look at Medicare and Medicaid, it's a little lower, but they're lumping in traditional Medicare, which has the lowest insurance administrative expenses. Why does Medicare have such low administrative expenses? They don't have to sell anything, market anything. Okay, they've got a uniform set of benefits, payments to the providers. There's work to do to manage it, but they're doing it for 2%. So if we look at other payers, and there's lots of other ones, why do we have to have lots of other payers? You've got to have healthcare in your slip and fall. You've got to have workers' compensation. You've got to have product liability. You've got malpractice liability. All those have healthcare built in. Why? Because we don't cover everybody. So we've got all this complexity and duplication. We've got hundreds of insurers with hundreds of different programs, with hundreds of different deductibles and hundreds of different co-payments and different deals with different businesses. It's almost impossible for us to figure out. As primary care doc, I can tell you one time when in the old days when we had green bar computers, I could probably walk across this room with that green bar for all the different people my practice build, all the different entities my practice build in 1 year. Now, the CBO recently took a look at what kind of is their vision of what the Sanders bill was, okay, which is a single payer improved expanded Medicare for all. They said that if they actually looked at the Sanders bill, it would probably cost about 1.6% administration. So we're talking about saving just on insurance administration by going simple, 10% of $4 trillion, $400 billion, $400 billion every year. That's going into administrative complexity and waste. How could that be? Well, this complexity has created an army of people on the provider side, an army of people on the insurance side fighting with each other over the money. And you can see that the growth in the number of people who have they never look a sick person in the eyes in the healthcare industry has gone from about the same, maybe double what doctors were. The bottom line is the number of growth in doctors. It's up 4,000% on people who don't do anything for patients. They recently looked at Duke Health System, which is 3 hospitals. They have 900 plus nurses, 1,600 billing clerks. I mean, this is what we're doing is crazy. First rule of holes, when you're in a hole, maybe you should stop digging. The next thing we spend too much money on is drugs. All these, I mean, when the federal government wants to buy staplers or pencils, they negotiate. But we were explicitly not negotiating in the US for our drug prices. And you can see what it means. We got a little old Denmark down here with about 7-8 million people there who are getting 75% off what we're paying. Now we're spending on the order of, I think pretty close to $600 billion a year on medications now. And now just recently in one of the bills that was passed, there was an effort to begin talking about negotiating on drug prices, but it's not going to happen for 4 years and it's for 10 drugs. I mean, it's like spitting in the ocean in terms of really controlling costs. And these guys don't want change either. And I have to remember that our money is our speech now. And you saw the other guys from the insurance industry, they can speak pretty loud. These guys can speak even louder. I think there's about 5 pharma lobbyists for every single congressional member. So they're out there running around all day long, talking to them about how wonderful the drug companies are. But look at this one guy from Regeneron. He's getting 120 million a year. We got 10 million people who got nothing. Now, a lot of the stuff that we've been trying that's contribute to our complexity is market forces. Market forces are never going to work. I don't have time to go into it, but they're just not. I'll give you a simple example. If open heart surgery was on sale and you needed it, would you have 2? Of course not. The things that we least want are the most expensive, most difficult, least negotiable. And so market forces can only kind of nibble around the edges. And so the idea that somehow market forces are going to cure, well, this is kind of, if you look at this slide, and again, you can't read it, I'm sure back there, but going top to bottom, that's kind of sequential in terms of the history of market forces. And during that same period of time, going from around 1990, when we talked about pay or play as a solution where the businesses either had to have insurance or put money into a public program, these are all the things that we've tried. And it ain't working. First rule of holes, guys. It's not working. Market forces, if they're going to work, we'd have them on the lowest costs and the highest quality. They're not going to work. And I could spend another hour talking to market forces. We have 2 bills now, one in the Senate, one in the House, Sanders in the Senate, Jayapal in the House. And both of those are for an improved expanded Medicare for all. Why is it the model? This is the most important piece. It's simple, right? Everybody in, nobody out. Okay, you don't have any restrictions on your network or what doctors you can see or could be a formulary. We should negotiate one, but your doctor's allowed to choose from that. Nobody's going to second guess them. And you get efficiencies, huge efficiencies. Again, just that insurance and billing stuff is 10%, $400 billion a year can be plugged into providing all these other areas here. It's guaranteed to all. Actually, the CBO did an analysis of this in December of 2020. And what they said was, yeah, you can cover everybody, even the undocumented. Just put them in there as well. Comprehensive coverage, limited or no out-of-pocket expenses. I think when they modeled, CBO modeled it, the only thing they put in there was wealthier people could pay a small copay for drugs. It controlled costs using global budgets. All the European people do it. We can learn from them how they're doing it using global budgets. You get fair financing. Let me spend a moment here. Right now, that's one of those CEOs from the insurance companies making $20 million a year. His family's getting health insurance from probably his own company for about $20,000. I mean, yeah, about $20,000 a year on 20 million. What's that? 0.1% of his total pay package. They do that right? 1/10 of 1%. So his $40,000 secretary, $20,000 for her. That's 40% of her pay package. So the poor are actually paying more. It's all upside down. It's all regressive. And a lot of this has to do with tax deductibility. But right now, if you look at total compensation, the poor are paying, or working poor are paying a lot more than the richest people in that corporation. So it's unfair financing. When you do taxes, oh God, I said that word, taxes. Somehow they've convinced us that everything about taxes is bad. Well, right before I came in here, I went to the bathroom and flushed. That's taxes, guys, all right? That's what happened. I drove here on public highways. That's taxes, guys, right? I saw the cops on the way here, keeping people from speeding. That's taxes, guys, all right? Now, you could give it a different name. You could call it a glumdelklitch. I don't care. What's going to happen here is we're all going to pay for all of it. And the question is, are we getting our money's worth? Second question, are market forces helping us? And to me, I've just given up on that idea altogether. And within this program, you'd have complete choice of doctor. You want to go to Mayo, get on the bus. You know, working for 40 years in Toledo, Ohio, there are very, very few people who I felt needed to go to some Mecca, whether it's the Cleveland Clinic or Mayo. But when they did, I had to fight with an insurance company or somebody else about it, or else they had to be wealthy. So these are the conclusions of that CBO report, Congressional Budget Office report, which is the ultimate financial scorekeeper. Improved expanded Medicare for all, a la Sanders, Jayapal. It would give us universal coverage. It would actually bolster provider revenues because now we don't have to have an army of people in our office fighting with the insurers about paying us. It'll be simple. You could even probably pay primary care doctors, give the patient a card and doctor a card that are smart chipped. And you both put your card in the computer, each put in your PIN, doctor puts in a code, boom, the money goes to the bank account. No reason for anything else to happen. They're doing that already over in Europe. Our expenditures, even if we left doctors have all the savings, if we let them have all the savings, and the hospitals who have tremendous savings here too, all of their savings, we would still save 40 billion. And the doctors and hospitals with these savings could easily take a haircut from their current payments. The only thing that the CBO could say that was negative is that maybe there would be delays in care. You know, maybe there would be lines. Well, right now, we have no idea what our lines are in America. No one is measuring what the uninsured, how long they have to wait. I don't know how you average in infinity, but nobody knows. There's no data on how long the uninsured wait for care. When they get really sick, they go to the ER, probably don't wait there, but then who knows what happens after that. We've got all kinds of people I showed you who are self-rationing their own care. So who knows how long our lines are. I can tell you for people with insurance, the waiting times to see a doctor, their primary care doctor, are about the same in the US as they are over in Europe, where most of these people are doing these sort of single payer things. So latest country to do single payer was Taiwan. They had a system like ours with a lot of private insurers. They had 30% of the population uninsured. They decided to do Medicare because they liked the trust fund. The trust fund is kind of like a lever. When the economy goes down, the last thing you want is for healthcare to lose its income because bad times make people sicker. Okay, we've known that since the TB epidemics almost 150 years ago. But bad times, being unemployed, that's real bad for your health. Anyway, CBO did an estimate on waiting times. No, they didn't. They just supposed it. And they did no effort to actually look at that. They just supposed that there might be waiting times. Right now, about 63% of Americans feel that government should assure that everybody has coverage. We still haven't come to an agreement on what kind of coverage, but that's the agreement, including about a third of Republicans. Now, I happen to believe that this is also a moral issue. And if you look at all these religious traditions, every single one of them has within it the golden rule: do for others as you would have them do for you. I mean, now we dug Saddam Hussein out of a rat hole in Iraq, and our best army doctors fixed him up just so we could hang him. Okay, so if you're going to tell me that there's somebody out there in your community who doesn't deserve my care, and do you want to be the doctor who is the moral judge of your patient? Do you want to be that doctor? Do you want that patient thinking that it's sitting there that you're going to judge them morally as to whether they're deserving of your care? I mean, that's abhorrent to me as a primary care doctor of 40 years experience. Who knows who this guy is? Who is it? Yes. This is the last slide. Who knows who this guy is? I'm ashamed of all of you. That's Frederick. Oh, somebody did say it. Frederick Douglass. That's Frederick. There you go. Thank you. Frederick Douglass. So just read this. This struggle may be a moral one. It may be a physical one. It may be both moral and physical, but it must be a struggle. Power concedes nothing without a demand. It never did. It never will. Oh, man. Just find out what any people will quietly submit to, and you will have found the exact measure of injustice and wrong which will be imposed upon you. Now, I just finished listening to a huge podcast called Revolutions. I highly recommend it. Very entertaining guy, Mike Duncan. One of the things that he says is that things basically have to get bad enough and unstable enough for real change to happen. And boy, oh boy, I think it's bad enough and unstable enough. We'll see. We've been trying for 110 years, and I'm going to run through the tape. You know, I'll tell you that. I'm going to run through the tape, trying to advocate for a healthcare system that's universal, simple, and affordable. And right now, with my background and expertise, I think that's an improved, expanded Medicare for all.
So thanks.
Now we're going to move on to the Q&A. It's going to be a lot more faster paced. So I have a couple questions to start for you all. And then afterwards, we're going to open it up to the audience questions. Rayhan has some questions as well that we've collected previously and over Zoom. And if anyone in person has a question, we have 2 microphones. We have one here and one here. We're going to prioritize you guys. Okay, that makes sense. And if you just wait by the microphone, we'll just call on you. So what I'll do is I'll set a timer for about 3 minutes for each direct answer. We're also going to allow some back and forth, but keep in mind, we do have a lot of questions to get through. Okay. That being said, I'm going to set up a timer for 3 minutes. First question is for Dr. Ross. What did you think of Dr. Archer's presentation?
We were sitting there whispering impolitely while our last speaker was there, but I think we have a lot of things in common. And for me, the common ground is we'll all be patients someday. So I think whatever you think about a healthcare system, you should be thinking about somebody you love or yourself, and how are you going to negotiate that healthcare system? And so I think any system should be judged on that basis. We're all going to be patients someday, almost 100% of us, unless we just happen to keel over. But the bottom line on it is think about it from that perspective, and think about it for the people that you love, and what would you want them to face in terms of its complexity. And I think that Dr. Archer's done a couple of pretty remarkable things. I mean, one of the things he mentioned was managing to wheedle his way through the complexity of Congress to get a bill to actually allow patients to, and this is in my sense, I think this is sometimes the miracles that we stumble across. He also mentioned to me the drugs that we now have for hepatitis C, which could be a fatal illness in the past, and now we've got drugs that can cure it. But we now have a drug for ALS. I mean, that was a death sentence in the past. So I think that we do not want to stifle our innovation and our research. And I think there's 100% agreement there. I think there's 100% agreement from my perspective that I do not want the federal government running our local healthcare. I mean, the nice thing about Medicare is that all it is a financing mechanism. They're not telling me how to practice medicine. The easiest cases I had to practice were my Medicare cases, because I knew the traditional ones, not Medicare Advantage controlled by private insurers, but the traditional Medicare, almost always I could get them what they needed. I didn't have to jump through hoops, play Mother May I, deal with complex networks or drug formularies. So for me, one of the things that convinced me that an improved expanded Medicare, and I think those first 2 words are important, improved and expanded, would be the way to go. You can't just take our current Medicare system and plop it onto everybody. There's too many holes and too many problems with it, in all honesty. But we know that Medicare is constitutional. We know that it is doing great for seniors. Just think about why they don't ever touch Medicare in terms of, there's always, it's the third rail of politics, messing around with Social Security and Medicare, because in all honesty, they work. And so to me, taking something that's uniquely American and using that is the way to go. Now, all I want the federal government to do, in all honesty, is collect the money. And right now we're doing it in such a complex and expensive way using premiums. It's way simpler to do it with taxes. All you do is set new tax rates for people to replace the money. And you don't have to hire a single additional tax collector to do that. You're just changing tax rates, more for the rich, less for the working poor. And you end up being able to gather the same amount of money in a much simpler way with a lot less complexity. Now, people might be skeptical about IRS, but I'm not. They seem to get to me every April 15th. So that would be my suggestion. And if you want then to give that money based on health service areas, have the hospitals submit a budget, have the community look at that budget and sign off on it, and then make them stick to it. And you've got the doctors on a pay scale. And basically you keep the doctors whole. You have to, you're going to have rebellion here. Keep the doctors whole, keep the hospitals whole, but make it simpler for them and allow them to keep some of those savings from simplicity.
Cool. So when I was flying here, just to comment on this Medicare, there was a fellow who was trained at Case Western Reserve. He is originally from New Delhi, and he's probably 60 years old. He went 30 years ago to a very rural town in North Carolina, and most of his patients are on Medicare, and he is basically a diabetologist. What do you think he was making in Medicare from his patients? Anybody have any idea what he was making?
Do our fellow panelists have any idea how there was making?
Well, I mean, was he an internist? I know what I made as an internist. I can
No,
tell
he's-
you
He's
that
an endocrinologist.
well, endocrinologists, oh my God. I mean, that is so unfair. They're going through 2 extra years of training and they've got no procedures to do, right? So they're making what a primary care doctor would with 2 extra years of training
Making
invested.
less than a primary care doctor.
Could be.
And he's making and it's because Medicare is not paying him.
But you see, but that's not a problem. It's just what are the payment rates? We're going to save what, $400 billion on
No,
the administrative
that's money you think we're going to save. It's
No.
not, it's
CBO. This is the CBO. This is Trump's CBO who said this, not John Ross.
I understand that, but
200 pages,
the
20
gov-
pages of
government
references.
accounting is a sham in general.
They weren't doing government accounting. They were looking at what the potential savings were. I'm sorry, I'm interrupting you. I'll just shut up.
No, I just think that look, in the ideal sense, I don't disagree with you. The problem is that how it actually works. And when you get into the system and I've been fighting and working on behalf of patients and diseases and, you know, I set up TB programs internationally. I had to fight WHO. I had to fight USAID to actually be the first in the country, in the world, to go from a 40% to 90% cure rate on TB in Central Asia. And we expanded to 5 countries. The governments and the Russian government didn't want to change. And the Russian government is set up exactly in the same way that you just talked about, where it just manages the finance and it gives money to the regions. And unfortunately, it doesn't allow the dialogue between that is essential for true innovation and reform. Governments are sclerotic. I've been working for 7 years to get CMS, Center for Medicare and Medicaid Services, and CDC to join epidemiologic and claims data. They will not do it. I put it in the law and they would not do it. Government is incredibly resistant to the things that Dr. Ross believes. In an ideal world, yes, I wish we could do that, but it doesn't work that way. When we built the ACA, the insurance companies and the drug companies designed it.
That's true. You know, it was Liz Fowler wrote the law. She was a health insurance exec.
So it's, these aspirations are very different than the practical world. And so I'm not saying you shouldn't want for everyone to be insured.
So here's how it happens. Every one of those people in that sclerotic government, we voted for them in one way or another.
No,
Yeah.
not an administrative state. And if you look at West Virginia versus the EPA, the courts just realized that there is huge overreach on the part of the agencies doing things that Congress never told them they could do. And there is a significant problem across all of the federal government doing things that are not constitutional and they're not in the law. So this is an overreach of the.
So what will happen in exchange for that is we're going to have more air pollution and more people die. I mean, to me, what are you going to do? You've got an environmental protection agency that you're telling you cannot protect the environment in that court case. I mean, to me, there's something crazy there, and I don't want to defend, the federal bureaucracy. But what I can tell you is, from my perspective as a primary care doctor of 40 years, who mainly had Medicare patients, I made a reasonable living and I took good care of people, made a reasonable living doing that. Probably 60–70% of my patients were Medicare.
So whether we are talking about Medicare for all or private insurance, part of the fundamental problem today is that the incentive system and the way we pay for healthcare does not work. We pay fee for service. We pay you as if you were making widgets. We pay you for X amount of dollars for a CPT code to come in and for a patient to come in for you to deliver a service. We know that does not work. It doesn't matter if the government's paying for it, and it doesn't matter if the private sector is paying for it.
Why are you saying that doesn't work? I'm not sure.
Because the outcomes,
90% of the healthcare system is running that way right now, true?
right, and it doesn't work.
Doesn't work in what sense?
Our outcomes.
Well, I agree with
So
you. Our
what-
outcomes
what-
suck.
what I
Not to
would
say it's
prefer-
for service. It
what-
makes our
what-
outcomes suck, I think.
Where I think the innovation and change can occur is we put the physician and the person delivering the healthcare at the center. And we say to them, I'm going to pay you to keep this person healthier. This company is going to pay you to keep you healthier. And the incentive system then is about making patients healthier, not covering for a particular procedure.
Are you
And
suggesting,
ultimately, that to me is the solution, not who is paying for the care.
are you suggesting like a system similar to the Veterans Association?
No, what I'm suggesting is we have the ability to shift the system into more direct care, direct contracting, where you, John Doe doctor, and 50 doctors who belong in the same practice with John Doe would contract directly with an employer and say, we are going to take care of your patients. And we'll be on the hook for the cost of doing that. You pay us X amount of dollars
No,
to
wait,
take care of that.
you're talking costs now, not outcomes.
No, No,
here's-
what I'm saying is, I know that I can make you healthier by doing it that way.
What are the
Okay,
consequences? if you
wait.
don't?
I can make you healthier that way, thereby reducing the cost.
So
And I'm on the hook for it if I don't.
what's that?
I'm
mean?
on the hook for it
What's
as,
that mean to be
as
on
the
hook?
delivery system.
So I
You
ran an
pay me,
HMO.
you pay me
for
$3
7
million.
years, let me
If it
tell you.
costs more than $3 million, I'm on the hook for it.
I ran an HMO that was a gatekeeper HMO where we paid primary care doctors, okay, on a capitated basis, all right? Who knows better how to avoid sick patients than the insurance industry? I'll tell you who, the doctors, because they know who's sick, they know who has
But
bad
with
health
direct
behaviors.
contracting, you
So-
eliminate that.
Well, how do you?
You
how do
eliminate,
how do
because you're on the hook with the employer.
Well,
You're
I'm
not going to get rid of the healthy patients. They have to come see you, or the sick patients.
Well, again, but so now I think to myself as a doctor, which businesses, and I actually did this for this HMO when I was in the business.
What's an HMO?
Yeah.
Just quickly.
Uh,
Health maintenance
We-
organization.
Well, we wanted to get bankers. We didn't want the Jeep workers. We wanted people in the suburbs. We didn't want people.
That's an old term.
Yeah, but we're talking capitation. He's talking capitation.
They don't may not know capitated either. You
Well,
gotta
that's what he's talking.
No, I know,
So,
but
so I
these are
guess,
terms that they all need to understand.
so I think where I think the focus of innovation can be is the physician or the healthcare provider assuming the responsibility of making the patient healthier can directly contract with employers. And I think it is happening my experience is it is happening successfully in Ohio today. It's happening in your community today. There is a large, innovative primary care practice in Northeastern Ohio that is doing this. And it is effective. And they are doing it, guess what? With Medicare.
Well, so here's my question for you. So how many of you think that you need to be paid to provide quality of care? You think you need to be paid extra to provide quality of care? Extra? I don't disagree there. Okay, I don't disagree with collecting data and looking at outcomes. But my question for you is, what is that going to do to your relationship with the patient? I mean, I watch this business of paying, contracting for a
Practice
group
is
of
doing
people
it successfully today.
because they probably knew who was sick. I'm sorry to say that, but you.
Or
look at
maybe the data is more sophisticated today and they actually know when to provide the care and who to reach out to that is sick and do innovation, letting them.
Do we
before
know
they
that?
Get more sick. We absolutely do know it.
Well,
That's how those practices are being
I-
successful.
well, I'd love to see the data because I'm telling you, I was involved in this whole idea a long time ago.
A long
Before-
time ago.
Before I became a single payer advocate, I
Before
was a
data exchange.
population care advocate.
Before data exchange.
Yeah, now, maybe again, do I trust the data? I don't know. You'd have to tell me more about what we're doing here in Ohio. I know there is a health information exchange. It
What do you
was a
guys mean by health
blessing to me
information
as a primary care doctor when I got information from the hospital across town
Sure.
who had happened to see my patient, which I
think-
couldn't
I
get
think We need to
before.
level set as Fahad gives us a question,
All right,
because
I'm
for
sorry.
them to
We're off
understand
track.
us, we have to.
How
help
about the
them.
next question? Yeah, yeah.
Okay,
How about
So,
the
like,
next question?
Just in terms of like the jargon and the diction that we use, we are medical students. So like, oftentimes we like, for example, I didn't know what a HMO is. We probably learned about it last year. I probably forgot about it, but
Yeah.
like, but
You don't want to learn about the hard way, which is kind of what I think I went through.
I guess like just to keep this, event educational.
This is
very
paying,
educational.
for the total care of a person. You get a certain amount of money per month. That's your pay, right? And so the more care that group of people need, the more time you're going to be spending taking care of them. You don't increase what you get for it, right? Whereas in fee for service, every service you get paid a little bit more. So that's the debate here is do you want to capitate physicians? True.
Capitate.
No,
Functionally, you're
That's-
capitating
no,
them. You're saying, well, the
that's-
business is
that's
handing
not what
you a
I'm saying.
population, and they're paying you a fixed amount of money for that population. Do they pay them fee for service? The businesses that are doing this, or are they saying, here's the money, make my employees better?
Yeah.
They're saying, here's the money, make my employees better.
Yeah.
That's capitation. So, I'm telling you, there's a
And it's
million
working.
difficulties
And it's
with
working.
capitation.
and it's working.
It's working in that one circumstance. I
Dr.
watched it drive me crazy for 7 years.
Dr.
So
Ross, I mean, you're making the point I made is the 90%.
I lived it.
80% of the conversations about finance, and now we're trying to have a conversation about delivery, and you're becoming frustrated, right? And that's what happens in Washington. People get frustrated about delivery because they want to talk about finance because it's the only thing they can measure. This
Uh-huh.
is really complicated over here, right? It really is. There have been projects, for example, Think, which is part of Blue Cross Blue Shield, did something where they put a primary care physician and a clinical pharmacologist in the middle of any patient in Medicare that had multiple diagnoses. And we were able to go from $40,000 a year to $14,000 a year for that patient by they had all these drug interactions. You've got multiple specialists around that patient. Nobody's at the center. These are the kinds of reforms we need to start thinking about to make it better for patients and for providers.
don't disagree with a single word you just said about that, because certainly my experience as a primary care doctor who had patients with 10 problems and 14 medicines, always had to think when they came in with the next concern, am I poisoning the patient? I mean, the fact is, the good chance you are with 14 medicines, actually probably 90% you are.
But I would also
so-
suggest that the systems and the technology that is now in place compared to really understand data and the health information exchange, those that are truly robust,
So-
can give us a lot of information about the
So-
patient and context over time that we didn't have before.
So you want to get back to questions, and I can
we have-
jabber with you
We have
later
quite a bit of
about
questions
this.
to get through. We do.
Okay.
So here's what I'll do is
I was going for hot.
So rather than asking one of you to respond, what we'll do is we'll have a discussion regarding each question, and I'll just have it for like maybe 4 minutes per question, and then you guys will just discuss it and
Yeah,
just
you
have at it.
just
Yeah.
wave at
Great.
us and
I
cut
think
us
that's a
off.
better. I'd
Better-
really love to have them asking us questions
sure.
directly too.
All right.
There's no one at the microphone right now. No one.
Come on, someone must have a question.
I have some right here from Zoom.
Oh, here we
Well,
go.
I wanna
See, we
prioritize.
got it. All right.
Hey,
Good.
people.
I actually had a question for Mr. Baker. When you were talking about how they were going to communicate with the Unite Ohio and all
Yep.
that, like certain data, I was more just wondering, like, who is that partnership that you were speaking of? So like when you're talking about the communication between public and private, or the communication between the social determinants and that,
Right.
who exactly are they getting all that data from? Like, because if I go to the grocery store, I don't know if I want everyone in the world to know that I was at the grocery
Sure.
store today. So
Yeah.
it's one of those things where I was wondering like how that actually interconnected and how
Right.
that would be exchanged in a proper
Yep.
way.
So the way it works on the clinical side today is that the main partners in the data flow are hospitals, doctors' offices, and insurers. Those are the main data flow points that are available on the clinical side. And for the most part, the government, in a lot of states, the government funded all of that. And now that government funding is drying up, so you have some constriction in the system. The way that we've made it work in Ohio is the users are paying for it. So the hospitals, the insurers. So think about, as soon as a patient goes, if it's a primary care patient that's been assigned to me, what this data, an example would be if that patient enters the ER, you immediately know. You get a notification. You immediately know that that patient has entered the ER. Now, what can you do from an intervention standpoint at that point? So the way it works today on the clinical side is that it's those larger clinical entities that are sharing the data. Now, to connect it to the community side is a bigger challenge. So initially, we're not talking about connecting it to Kroger or to Giant Eagle, but we're talking about connecting it to food banks, to housing related projects, to, for example, YMCAs who are involved in smoking cessation, for example. So community-based organizations that are involved in taking care of people's health, but not from a clinical standpoint. So it's connecting those worlds from a data standpoint with the clinical world. That's what Unite is trying to do. So we have a platform over here that already does that in the community-based world. And we have a platform that does it in the clinical world. The job now is, how do we connect those two worlds together?
Thank you.
Just
That
one
makes a
other,
lot
I
more
think
sense.
this is really important because this, what we're starting to see in the health information exchanges are evolving into something called health data utilities. And when you start adding the social constructs like child welfare and foster care and even in jails and all of the places where people go in the system, you can begin to understand more about the wholeness of that person, that family in the context of a community, and then the richness of that. And if you layer that on with the clinical data, and then one of the projects we're doing in North Omaha with the Black community is we went in and we assessed where is the highest rate of asthma. And what we found is that in one part of the city, we had 3 times the rate of asthma as anywhere else in the state. So we're going into those census tracts using this health data utility with all the data that Mr. Baker's talking about. And we're able then to work with the community. And what we're going to do is create a community shared savings account. So as we improve an outcome, we're going to pay the community so they have money to spend on the social determinants that they want. We want to create a virtuous process of using this data so that the community is truly, truly engaged. Then we'll start working on food systems and other things because it all matters. Everything matters where people are. It's not one thing.
We're gonna
And
have
I
to
know,
probably move on to the next
but
question.
Yeah.
just from your privacy concern, the patient has to opt in. If the patient doesn't want their data shared, their data does not get shared.
Thank you. That makes so much more sense.
So you guys want to go on to the next?
Shifting a little bit of the conversation, I know prescription drugs were mentioned a little bit, and I remember one PowerPoint slide where prices per capita in the United States or for each drug are like overwhelmingly higher than in other developed countries. I think one bill that was put into Congress, like most favored nation pricing. I guess, what do you guys think about that?
3 minutes.
You want to start?
Yeah. So for me, I think that, there's no question in my mind, we need to throw a rope around big pharma. I mean, you saw the CEO incomes. Most of the research, the real serious research is done with NIH money. That's our tax dollars. What we do then is a lot of that information then spills over to the drug companies and they do the trials and that's expensive. I don't want to say that they aren't playing a role in that, but most of the actual innovation is happening through our academic institution. And as a physician, I can tell you that there was always V2-mycin, right? There was just this, the drug companies looked at the molecule, figured out how to change one little edge of the molecule to make something that looked just like another company's drug, but was patentable because it was uniquely different. So we have real problems with the way we approve and with the way we fund our approval process. Right now, the whole FDA is under the thumb of the drug companies. They basically pay them to do the analysis of their new drug. So we have lots of problems with our drug approval
But
process.
I want to go to his other question because a lot of other countries have what are called health technology assessments. So England has something called NICE, National Institute for Clinical Excellence. And what they try to do is determine whether a drug is useful in the clinical sense and what they're going to pay for it. So in Europe, you get an approval, but then you have to go through registration, which is the registration is the payment mechanisms. So there's no doubt that we overpay for our drugs. 2/3 of the cost, 2/3 of the revenues from pharmaceuticals come from the United States as compared to 1/3 from the rest of the world. But let's go back to this question. There are certain drugs like generics that now FDA doesn't allow the manufacture of adequately. And so there's no competition. So old drugs that ought to have been very cheap are now going like this. 60% of the APIs or the active ingredients are coming from China, and most of our drugs are being made in China and India. And we have no way to actually verify that they're actually not adulterated. So our system is really messy, and it's not very good right now. It's not just a cost question, but we don't have a regulatory agency that's set up to actually manage this. And secondarily, again, government has created the formularies inside of Medicaid and Medicare, which then are driven by government, which then pay the middlemen, and 80% of the costs are going to the middlemen, and that's why our drugs are so damn high. So,
Well, again, I don't want to defend the Medicare Part D drug bill because I protested it. I thought that it was a sellout, but
the other thing I'll just
tell
say
you
is
about that bill is
that
the payoff to
that
the.
all of our drugs are made in blue states. So ask those blue senators why they don't actually do something.
Now we
I'm
have
glad
another,
you made that louder.
Thank you.
now we have a question from Rehan from the chat.
Yeah, so we're gonna alternate between in person and on Zoom. So this question is for everyone. If the majority of physicians and Americans want universal health care, how are we best able to get it enacted when industry clearly has the ears of our politicians?
So you're saying the majority do, if the majority did want it, how would you actually
Correct.
get it done?
This is from Andrea from Charlotte.
Got it.
How would you get it done?
He basically, Rayne has told us that he doesn't think it can be done. He thinks our government is so hopeless that it can't be done. But I think that depends on who we elect. And it also depends on what we demand, right? As I said when I quoted Frederick Douglass up there, if we don't demand it, we won't get it. Basically, we have to insist. We are the DNA. You guys will be the DNA. They can't have a healthcare system without doctors. Can't be done. So they can't do it without us. If we simply say this system is inhumane, unfair, badly financed, too complicated, it's got to change, and we stood up and advocated for it, I think it would change. And you can advocate it at any of the levels that are here, to be truthful. You could advocate at this sort of public-private cooperation business, but that it's this complexity that's killing us. Right?
So I was just gonna, what I would say is, to answer the question, you have to be okay with it being incremental, because it will be incremental. That is the way both our national and state government are set up. So you can have the goal be X, and you can work towards goal, but don't be unrealistic to think that that's going to happen tomorrow or a year from now or 2 years from now. You need to take the wins to get you to that finish line. We have a medical student work with us as an intern every year between year 1 and year 2. They come down and they go to committee with us. They get involved in interested party meetings with us. And if you talk to any of those folks, they're startled by how the process works, even at the state level. But it takes time. It takes time. So you can't get frustrated, and you can have that goal, and it will take continual work, but you have to accept that it's incremental.
Well, I would argue there's good incremental and bad incremental. Okay, I think we've been doing a lot of bad incrementalism lately. We really have. And so for me, good incremental is when you cover more people, because I think the system should be universal. Good incremental is when it cuts costs rather than increases costs. And the more complex we make it, the more it's going to cost. All right. And I think it needs to be affordable for ordinary families. And right now, the financing system is completely upside down and regressive, where the rich are paying less of their total pay and the poor are paying more through private health insurance. So I think you've got to look at this whole thing and say, well, what's good incremental and what's bad incremental?
I would argue that there's a lot of Ohioans that benefited significantly from Medicaid expansion in the ACA.
Absolutely.
And so Those are our most vulnerable, and they're much better off today than they were 10 years ago. That's good incremental change.
But remember that was fought
Gonna have
tooth
to
and
cut you
nail
off here.
by people on the right.
Yeah,
So
we
a lot
have
of
questions to get through. So, Emily.
I actually have a question for Dr. Archer. I wanted to ask about a point that you made in your presentation. I'm just having some trouble with what I understand as kind of a logical inconsistency. So maybe you could help me understand that. Your slides included the phrase, insurance and good access are not associated with better health outcomes. And I mean, first of all, that seems a little counterintuitive to me. I'd appreciate any, statistics or citations you could offer on that point. But, assuming that you believe that to be true, I'm not really following why you think that insurance is like a good solution to the problems in our country. It seems like, is insurance good at keeping people healthy, or is it not good at keeping people healthy?
So the main purpose
3
of
minutes.
insurance is making you feel secure. The main purpose is to not make you feel afraid. Fear is a terrible thing to have, and to not have a mechanism to solve the problem that you think is important is really the main reason for insurance. But just because you're insured and just because you have access does not mean you're going to have a better outcome. And the evidence for insurance and access in many states is that if you look at those states, for Tennessee and Massachusetts, for example, who were the first to try to get to universal coverage, and both of them got into the 90+% level at one point. And what you saw is, even as the insurance rate was going up, the life expectancy was going down. So the point is it doesn't mean that when you're sick, you don't need to see the doctor. It's just that there are so many other variables that need to be accounted for in order to understand the role that insurance plays, access plays, and social determinants that we've been talking about are very important. But I still think we have a long way to go to understand them, because again, I'm going to say, people think that social determinants is about sprinkling Santa Claus money around, and that's not the solution.
I mean, here's what we know. People who are uninsured, for every 1,000 about, actually a little less than that, every 1,000 people uninsured, somebody's going to die. That's pretty hard numbers, and those have been researched pretty carefully. So I'm sorry, having health insurance definitely saves lives. That's number one. Number two, I mean, the quality of that insurance matters too. I showed you 50% of Americans are self-rationing because they're worried about out-of-pocket costs. I mean, and you can't expect people to think to themselves, gee, this chest pain, maybe it's nothing, or maybe it's a heart attack. And then they finally say, oh no, I'm going to go ahead and spend the $50 to go see Dr. Ross. And they come in and I say, I don't know either. And I'm going to have to do some very expensive tests before I can tell you. I mean, what we know is co-payments kill. We know that from RAND studies, that co-payments kill people. So from that perspective, first of all, universal health insurance will save lives. CBO says it's going to save money, okay? And people are already self-rationing care. So to me, I think there is a benefit to insurance, and people consider it the number one thing they want from their employer is having actually healthcare coverage. And maybe it goes back again to being worried, but you're almost like denying that we as doctors do anything when people do come in to see us.
I'm
Now
not
we have a
denying that.
question on the Zoom.
So this is anonymous question for Mr. Baker. What are the OSMA's largest objections to single payer reform, and are there any circumstances that would modify this position?
What was the first part?
What are the OSMA's largest objections to single payer reform?
Right. So the process that we have to change a policy is we have what's called a House of Delegates. So any individual member of the OSMA can submit, think of it as a piece of legislation. You could submit a resolution that says, we think that the OSMA should support single payer. And then that will come to our House of Delegates, and the House of Delegates will debate it and vote on it and say, yes, we think we should, or no, we think we shouldn't. And we go through that process every year. And we probably have anywhere from 15 to 40 resolutions each year on macro level topics like single payer and on very specific topics like the OSMA should, one we had this year was advocate for free parking for patients at hospitals. Okay, so that's the breadth of the kinds of topics we can. So any member can bring it, and the House of Delegates debates it, and our policies can change once a year. And so the first part of the question is, quote, why are we against it? I think the last time we had policy on it was probably during the ACA, so 14 or 15 years ago. And there was still a fundamental feeling, I think, within that debate in the House of Delegates, that we didn't want to put the government in control of all of healthcare. That's probably the biggest thing. But any member can submit a resolution to change a policy that the organization has, and then the delegates debate that policy.
Right now, we should recognize who has control. It's the insurance companies. So you got a choice here as doctors. You can have the government, which is our government that we vote for. We can be activists as physicians to advocate for better policies, or you got private people.
Well, no,
who
because
their money
government
rules.
controls over half of healthcare today.
But it's all been privatized. It's in private insurance. Medicaid, what is Medicaid privatized? How much of Medicaid is under private insurance companies in Ohio?
It's administered by private insurance
There
companies.
you are.
That this year, starting February 1st, every claim you submit will go through the government, a fiscal intermediary. So,
My time
So
went
my-
off. I just forgot to,
yeah, go ahead.
sorry. We have time for one final question.
Okay, I want to thank everyone on the panel for coming today. It's obvious that you all are doing fantastic work and you're very knowledgeable on the subject, so thank you. My question involves the social determinants of health, which we've talked about pretty extensively during this debate, but we could talk about for hours more. The social determinants are countless, but a lot of them are linked, poverty, housing insecurity, food insecurity. But when we're looking at these outcomes, I agree they're very linked to a wide array of these social determinants. But if we're focusing on uninsurance, by definition, as one of the social determinants of health, I don't think anyone is saying that single payer is like the panacea for all the medical and healthcare woes that faces our country. But my question is, do you think single payer healthcare would be and would help improve challenges that people face with the specific social determinant of health and the impacts of uninsurance?
If you wanted me to build a new healthcare system, there would be no wrong door. When you came to me because you had a knee pain, and I found out that you're living in a 3-floor walk-up, there ought to be a way. And this, I think, goes back to some of the things Rayne was saying. You've got to integrate the social services and this goes back to what you were saying about connecting through Unite to programs that provide these services. I mean, we have not integrated our social services with our healthcare. I mean, they're completely separate. Public health is over here. Food banks are over here. I mean, the fact is that the more we could bring together the things that make us healthy and to kind of create, and what I guess is kind of exciting, I just heard and haven't really thought about this before, is how much of that could you do electronically? Right? You've got the data already, this person, so we need to be able to say to our patient, I can't help you with the 3-floor walk-up, but Sue up the hall, who's the social worker, knows the people at the Public Housing Authority. Maybe we can get you moved to the 1st floor. I mean, it's that kind of stuff again that we just don't link together. And in other countries, even poor countries like Cuba, that stuff is all linked together. I mean, it's completely integrated.
So the answer is, in my opinion, the answer is a single payer wouldn't guarantee that.
No.
Necessarily.
Have to construct it to make it happen.
To your comment about it being a panacea, I don't think it would solve under its current construct. If we dumped everybody in Medicare, it would not solve for dealing with these social determinants of health. We have to figure out other ways that we can connect those two worlds together in a much more efficient, effective way. Maybe that's somewhat dependent on, quote, the payer, but I'm not convinced that it is.
So I'm a program director for the American Public Health Association. We put on papers every year. And the strongest supporters for single payer, improved expanded Medicare for all are in the public health community, with some exceptions like Dr. Rayne here. But in fact, I mean, it's like a no-brainer there in terms of whether that's what we ought to do. So I think the public health community recognizes that our current healthcare system is not integrated to do all the social determinant side. And we're certainly not as physicians set up to do it either. And so I guess I would say it would be certainly a lost opportunity if you were in the process of saying, okay, how are we going to expand Medicare to everybody? And how are we going to fill in all the gaps in Medicare? How are we going to make it simple? It would be a lost opportunity if you also did not try to integrate the social services that are going to more directly be beneficial than medical care alone on the social determinants of health. Many of those things that we could deal with, they would pay for themselves. You know, early childhood education, Oklahoma was the first state in the country to do early childhood education. It convinced a very powerful Republican that it was a good idea, and he slipped it into a bill that everybody had to pass. And that's how Oklahoma got early childhood education. So I mean, it can be done.
I just wanted to make one comment on this because I really appreciate your question because it's very thoughtful. And I think our goals across all of this are very similar. The question is, how do we get there? And I do think people need insurance. One small problem is just because you have an opportunity to be insured doesn't mean you will be insured. In Canada, people, I think it's 93% that have signed up for insurance. In some states where they're fully insured, you have the potential. There's still what are called Medicaid eligible, not enrolled. There's a significant problem in that regard. But I would offer that I really believe that what I'm seeing emerge as a more ideal way is a public-private partnership where the idea of, I do think the costs are too much in the insurance companies. I think we should drive some of those out. But I really think the government has to be as accountable as the private sector to the process of innovation. And if we could do that from the beginning, where we set that up as a public-private partnership, I think we can get closer to both funding the system as we need to, but also doing the parts and pieces of bringing things together. I don't think a single government solution, and I will also say, as we see with DOD, VA, and Indian Health Service, when the government pays for it, eventually they want to take it over and do it too. So that's another thing that could also happen. So I appreciate your question. It's very helpful.
Cool.
And I will put in one last plug that membership in the OSMA for students is free. So during your time here, if you have not already joined, and at a minimum, that means you'll get communications from me 2 or 3 times a month that will keep you updated on what we are doing in Ohio related to a lot of these topics. So osma.org, sign up to be a member. It's free. You can, and my email is tbaker@osma.org. Feel free to reach out to me at any time, but I would encourage you all to be members, to start that advocacy journey if you are not already, and to have a voice in the process as we move forward.
For sure. I just wanted, we are over time right now. Just wanted to thank everyone for coming. Hope everyone learned something from this discussion. I also want to thank all the panelists as well as the OSMA, the Benjamin Rush Institute, the Physicians for National Health Program. I wanted to thank SNAP team, specifically Rehan and Michael Massey for helping to organize the event. And if you need any contact information of any of the speakers or want to come up and speak with any of them, feel free to come up and speak with them. And yeah, just a round of applause for everything. Thank you.
Thank you.